Hi everyone, and welcome to our second webinar on communication in all directions. My name is Stephanie Quillen, and I will be the moderator on today's webinar. Before we get started, I'd like to draw your attention to some important webinar logistics. Today's webinar is being recorded, and you are currently in listen-only mode. You may send me questions for the speaker at any time during the webinar. Simply type your question into the dialog box to the right of your screen and send it to the organizer. We will answer your questions at the end of the webinar. And with that, I will turn it over to Joan to introduce our speaker.
Hi, everyone. It's great to see your names popping up, some people I know and some people I haven't met yet. Cherry, it's nice to have you on. And looking forward to this second in a series of webinars for those of you in Montana, both who have state grants and Montana Healthcare Foundation grants, and also other interested folks. And I'm happy this afternoon. One of the reasons I love these webinars is it gives me an opportunity to introduce my great colleagues to you. And I'm happy this afternoon to have Pam doing this webinar. Pam has a tremendous wealth of experience working in primary care, and in addition to that is a wonderful motivational interviewing trainer and just a great webinar presenter. So really looking forward to hearing what she brings to us today. Pam?
Great. Well, thank you. And thanks, everybody, for joining me on this Friday afternoon. I was pleased when Joan asked that I would talk a bit about communication. As she said, I do a lot around motivational interviewing, and I really think that the way in which we deliver our messages and the way in which those messages fit within the context of our environments makes all the difference, right? So what I'm going to do today, we can go to the next slide, is I've got a kind of a hodgepodge of things that I thought I'd introduce to you, but I want to do it in a very linear fashion if possible. So what I'm going to present to you today is actually, if you go from the bottom up on this agenda, rather than starting with the specifics, we're going to end there. So I think in order to really maximize your engagement within your team, with the people you serve, and make a significant influence, we have to be able to have teams functioning in an optimal way. And from there, in order to have teams function in an optimal way, we need to have our change messages and understanding the context in which we're in and the change surrounding us to start things off. So we're going to go from this big picture down to the specifics on the ground. How do we engage and influence? So starting with that big picture and cascading down. So starting with change messages, we can go to the next slide. And actually, let's just keep going on to the next one. So if we think about messaging change, first of all, I ask that you stop and think for yourselves, where are you and where is your team in terms of change? Are you attempting to hold back those blades of change? Is it this fear that change is going to disrupt everything I've ever known? That's a very common response. It's also challenging the way in which we're used to working, our comfort level. What we went into the field of behavioral health or health care, it's very understandable that at times we may want to hold back the change. So where as a team are you? Are you in front of it? Are you at least in step with it? Are you parallel to it, or are you chasing it? The world is clearly evolving, funding evolves, and teams evolve, and it's something for us to first think about as a team. Where are we collectively? If we go to the next slide, I want to say something about this concept of what's called adaptive reserve. So there is this article that was put out in 2010, and it was written for primary care, but I think it's very adaptable to a lot of different situations. Adaptive reserve is about our ability, our capacity, our tolerance, if you will, to not only sustain change, but to make it in the first place and then sustain it. And what this article goes on to say is that the way in which we collect very strong adaptive reserve is by having, first of all, a shared vision. Is everybody around the table aware of where we're going and why we're going there? Is everybody's vision aligned with the purpose of the work that you're doing. To get to a shared vision, we have to shift the way we're thinking about the work we do and develop different mental models than perhaps what we were thinking when we started this position or even when we went to school in the first place. It's really being okay with raising that issue and having people really talk about what is uncomfortable about this, what is going to be different about the work that we're doing today compared to a year from now. How is it already different from, say, the way we were working a year ago? And all of those conversations help us to collect stronger adaptive reserve so that we can weather the changes. And then lastly in this slide, I want to mention this quote that came from the article that, you know, we're in the business of transformation, right? We are clearly, healthcare is transforming. And it doesn't occur in a very predictable way, which is stressful. It can be very chaotic to feel like we're making 2 steps forward and maybe 3 steps back at times. But to know that transformation really occurs in fits and starts, and it may not feel like we're making progress, but as time goes by and if our teams continue to go back to what is our vision, what is the mental model that we're working in right now, it helps us adapt to those fits and starts. So in the next slide, talking a bit more about organizations and change and how do we communicate where we are at as an organization or as a team. And I really like this thinking that, and for me especially, I'm a very detailed person. I like to get to the how. I'm very practical. I want to know, all right, I get it. What are we going to do next? Let's do it. Let's figure out how to get things different and how to make it happen. But we can't jump the gun on that. And in order to be effective in our teams with communicating, we have to start with the why. We have to talk, and that's that shared vision again. Why is this change something that our organization is embracing? Why do we individually want to be part of the change? It really comes down to what does our organization bring to the community, to the consumers that we work with, to us personally as staff that participate within that organization. Really wrestling with the why is the role of senior leadership. And if they can give a clear message of why are we here, what benefit are we providing, and why is this change good for us, it can really help then as we as staff think about the change that's coming. So we start with the why. The what, it's interesting because I have a colleague that will often say, you know, we almost don't get to choose the what. The market chooses the what. And if you think about what the market is demanding from us, what clients and consumers, patients, whatever word you use, what are they wanting and demanding? They're demanding better health care, higher quality, more affordable health care, and truly that integrated care. People are coming in saying, you know, I need this one-stop shop. I need to know that I can come in and you guys can sort out and help me sort out what it is I need to be healthier. So the market is really demanding that we change. And what we can do with that is say, okay, so if it's already happening and it's something decided already, how can we benefit from it? How can our clients benefit from it? And then we can get into the how. And that's where we really want to give the work back to the people that are doing it. So the people that are working with our clients, the supervisors that are supervising those frontline staff, they are best positioned to know how we will do this change. How are we going to get there? What things do you think would make sense in this new world of healthcare? If you're clear on the why and the what, the staff are best equipped to help us decide how we're going to get there. So with that, we can go to the next slide and just a couple more things on this big concept of change. I really love this idea of technical versus adaptive. It comes out of some work that Ron Heifetz has done out of Harvard, and he talks about 2 different kinds of change. There's, first of all, the technical changes, and these are things like we need to implement an EHR. We can't just work on paper records. We know that that isn't keeping us as efficient as possible, and we know we need less manualized information. So the problem is well defined. We've got to transition from paper to an electronic record. And also in a technical change, it's usually pretty clear what we need to do to get there. We need to start with this, develop a project plan, find a vendor, test it out, develop the product. Technical changes are necessary and important, and what Ron Heifetz has said is that complex change really doesn't fit into that mechanism of technicality, and that's where adaptive change comes in. And these are things like, we want to implement an EHR, but what does that mean for the way in which we work, what we're used to as clinicians or providers? You know, when I was doing therapy years ago, I sat with a notepad and talked to the client and took some notes along the way, and later went back and probably didn't even type because I was still probably handwriting my notes and sticking them in a file. So how does that change my role? How does that change the dynamic of the relationship with the people I'm working with? It's those other factors around a change that we don't always remember to attend to. And this plays into that idea of communication, because as the team thinks about any kind of change, we want to be paying attention to what are the technical aspects and what are the adaptive aspects. And one more slide on that, we can go to the next slide, that these are some examples of things that fit both a technical or an adaptive change structure. So I started, as I gave the example of EHRs, you know, implementing a new tool. Say it's, you know, we're going to start using the PHQ-9 for depression. It can be really easy to say, great, we're going to have a really good depression management program here. We've got this tool. Here we go. This slide is saying that that's really just the tip of the iceberg, because within those tools and those technical aspects of a change, it's all of that underlying stuff in red. Does our leadership support the workflows, the time, the efficiencies, the testing of processes to support implementing PHQ-9? Or is the staff, does the staff believe that this is a good change? Do they believe that that tool can help them with their clinical diagnostics? Are staff comfortable with using a tool such as this? Maybe it's that this is now going to be something the front desk person hands out. Are they comfortable with what they're going to need to say to get a client set up with completing this particular tool? And then all of that comes back to the very bottom of this triangle there, that shared vision and the shared accountability, that we as an organization want to move in this direction, and we're going to hold each other accountable and support each other in making this new process happen. And then what you see there in blue or bluish green, that what Heifetz has found is that the most common cause of failure from our leaders is when we take something that is actually adaptive, very complex, and we just apply a technical fix. So we have to have, there's time and place for both kinds, but we have to think about the bigger impact that technical changes have upon our values, our staff engagement, and leadership support. So we can go to the next slide. So that's that big picture of how do we message and set ourselves up for successful change. Now let's drill down a little bit more regarding team functions. And the next slide is, I believe last month mine and Joan's colleague Jeff talked with you, and he used a picture from the A-Team. And I like to use this picture from Oceans, I think this is Oceans 12, if I'm not mistaken. What I loved about this movie is just the idea of they brought together all of these different experts. If you've seen the movie, you know they had the computer genius, and they had the acrobat that can squeeze into tight little places. They had the smart operational person. And I liken it to, what does it take to have a high-performing team? How do we use people to their maximum strengths and yet make them cohesive so that they're working toward the greater goal, which in this case of the movie was I think a major theft of some kind, right? It was something around Las Vegas and stealing jewels and painting. So we aren't going that route. But certainly that same idea of bringing together the right people at the right time. And the next slide is my way of translating that into the work we're doing, that, who makes up your different teams? Whether you refer to the people you serve as the client or the patient, they're in the center of these teams. And then what makes up the best team? In my years of working with different clinical groups, whether it be in behavioral health or primary care, I always challenge the leadership to go back and say, what do we need in order to support the people we serve? Some teams will say, gosh, we have to have peers. That's a core of the work we do, or it's part of our regulatory requirements. A peer is a part of our team. Another one might say, we've seen huge benefit in having a pharmacist as part of our team, or an addiction specialist, community health worker. All these different titles and job functions, in order to move on to the next step of communicating, we have to know that we've got the right people for the right work. In the next slide, I want to emphasize too that team-based care really comes from, this first bullet is most important. It's more than just adding a certain person and saying, now we are integrated. Now that we have a care coordinator on the team, we're ready to go. Or now that we hired a social worker, she or he will take over seeing all the people we work with that have, serious mental health issues. It's so much more than that, and it's more than just dropping in Mary Poppins to make everything okay. It's how does adding this person now force us to rethink everybody's roles, what everybody is doing, so that we really optimize the whole team. And that can include everything from the back office to the front desk staff and everybody in between. And to what degree do we need to have cross-training? I was working with a group of clinics last fall that decided to really, they kept thinking, where do we get expertise and where do we get training on this topic and this topic and this kind of thing? And they realized they really had it internally, they just didn't have people talking to each other. So a great way to get communication going, to get team members trusting and getting to know each other, is to have them cross-train each other, so that they can both feel like they've got some confidence in they do know their job area, and they can disseminate some of that to their colleagues. So cross-training is a great opportunity for nurses to teach mental health staff about some of the key physical conditions. Perhaps you have someone on your staff who is very effective with doing concurrent documentation. They can do some cross-training with other staff. Clearly, all of this takes a lot of trust, which takes time. It takes the willingness of everybody to say, hey, we want to be part of this because we believe in that shared vision. And to what degree can we create some protocols or standing orders, as they might call them in a physical health setting, some things that really help make it clear what should be done as people come in the door for certain conditions, or certain processes that you've finally figured out that you've got written down so that everybody can follow that same process. The next slide is really the importance of having expectations really clear on what everybody's roles are. So as the first bullet says, the more complex the task, the clearer the roles have to be. And we work in complex ways. Virtually nobody we see in healthcare is very straightforward, simple. This is someone that has just depression, or this person, really has high blood pressure, but otherwise they're completely healthy. We just in reality don't see a lot of simplicity. So the more complex the work is, the more we've got to be clear on who does what. And we have to discuss where people are confused, where there is some expected redundancies, if there are some, and knowing who's going to own what pieces of the puzzle, and giving, again, that work should go back to the people that do the work and have them really thinking about what is it that you do versus what another colleague does. In fact, if we go to the next slide, I think it's the next slide. Yeah, this is just a very simplistic version of a worksheet that you could use, where along the left you lay out all of the tasks. And you might start with just one clinical condition or something. You might start with, say, if you do SBIRT, what are all the tasks in doing SBIRT? You know, there's screening the person for substance use risk, and then there's doing a brief intervention, documenting the level of care. Whatever it may be, you just line up on the left all of the tasks that you want to evaluate, and then you have each staff person that could be involved in that work. Think about whether that's something that they see as their role. And if it's not their role, who do they see as it being that person's role? And what would it take for that person to do the work if they had more training and support? So the very first pass of using a document like this is just to give everybody that little bit of independent time to fill it out, and then coming together and really reconciling the differences in those worksheets. People have found it really eye-opening that what we think is our role, someone else might think it's their role. Or, wow, I've never done that because I always thought you were doing that. Turns out nobody's been doing that. Really interesting conversations come from doing this first separately and then coming together. And that last column there on the right is that opportunity to say, gosh, you know, would you be willing to do that if you had more training and support? I've seen lots and lots of people say, you know, I'd love to do that. I don't know how to do it, but it sounds interesting. What would it take for me to do that role? Now, of course, we're always thinking about what's within our medical or health licensure, but this is also about saying that there are a lot of things that could be done by a lot of different people depending on the setup of your organization, the strengths of those team members, and how you're configured, right? Back to those earlier concentric circles. Who do we have within our team, and then who is it that could do these things? What comes from this worksheet is also recognition that there will be some gaps, and that can help you decide, wow, we're going to need to hire, you know, a LPN. They could do these pieces that are remaining. Or, wow, we have 3 people doing the same task. We really only need 1 person. And then what do we do with that information? The next slide, if we think about then the relationships between all of these people and all of the work they're doing, I think it's good to be thinking about, you know, what tasks or what job functions should be everyone's job, and then what tasks are unique to certain people. It's kind of that specialist versus generalist tension we often feel as we're doing more integrated care and more blending of work and roles. There may be some things that fit within the organization that you say, you know what, it's everybody's job if someone walks in crisis, that they, you know, sit down with the person or they call for assistance or whatever it might be. Or it might be, you know, if someone walks in with crisis, we all have one point person that we bring to the front and have them sit with the person. Whatever it may be, knowing what's everyone's job and what's unique. Also workflows, again, that really is best owned by the people who live them. So sitting down with those staff and saying, you know, what is your normal process? How is it? What do you do at this point? Who takes over from there? Where do you put that document after you filled it out? What do you do if that next handoff person isn't available? You know, warm handoffs are a great thing if they truly are a warm handoff, meaning we are able to at least briefly introduce that next person. For a social worker to say, gosh, we have this great health navigator on our team that I'm going to bring in because she's going to be able to sit down and help you look through those materials I just handed out and help connect you with, you know, a support group. So handoffs where it's truly able to be warm-handed off, and that the other piece to that is I've seen a lot of groups where there's some inefficiency in physical location of the people that are part of the process. So if I'm the first clinician and I've got to walk down the hall, around the corner, and up the stairs to get that care coordinator, I'm probably not as likely to do it. Or if I'm telling the client, go down the hall, turn the corner, and go up the stairs, are they likely to follow through? So how are you physically set up in your space to really optimize handoffs and the necessary ones. And then the last thing on this is I know there's an interest in huddles, and that too is about maximizing space so that when you bring the right people together for those quick daily huddles, ideally, it's quickly standing up, 10 minutes, running through the whole schedule. Someone wants to be very mindful of the time so that they aren't long, because you will have people that say, oh, that's a waste of time, or, I don't have the ability to attend those meetings. So I provided a link to a nice brief example of how to do a pretty optimal huddle. So next slide is a polling question. I've talked at you enough, and I'd be curious to know an example of one of the things I've talked about so far. Team huddles. I'm curious if you use them now, and if you do, how often do they occur? Do you do daily huddles? Do you do weekly? Are you not sure because sometimes you meet, sometimes you don't, or is it that it isn't something you've yet implemented?
We'll give everyone a few more seconds.
Okay, great. So half of the people on the webinar today have daily huddles in place. That's great. And quite a few have weekly, 8% not yet, 17% unsure. Yeah, at this point too, I welcome comments or questions in the chat box or however else we can make it happen. Curious what others are experiencing when it comes to huddles, or certainly anything so far that I've talked about regarding setting up your teams for change and some of these operational aspects of teams. So I'll pause for a minute here so you can think of questions or submit something in the chat box. And Stephanie, do we have anything, or should I keep going?
No, we don't have any questions coming in, so we can move forward.
Okay. At any point, if something comes to you, don't hesitate to use that chat box. All right, so we've got quite a few daily huddles. That's great. If we think about some of the strategies, what I did with this slide is I was thinking about what have I heard from some of the teams I work with. So it isn't just me talking about what sounds good. These are some themes that have come up over and over about what makes my team work well together. And the first one I had mentioned earlier is cross-training. And I've had people say, you know what, we have a lunch hour where someone from the team, we eat lunch and they talk to us for about a half an hour about good diabetes care. Or we have a psychiatrist come in and just kind of educate all of our staff about psych medications, just on a very high level. It helps us get to know that person that's speaking. It gives us more information and gives us a little bit of common knowledge so that we can do our job. The bottom left corner there, planning meetings versus work meetings. This has come up too, where people have said, we have productivity standards we need to accomplish, so when we have meetings, we need to know, is the intent to do some planning, or is the intent to actually do some work? Not that planning isn't work, but there's this different intention of work is everybody's talking, everybody's writing things down. Maybe it's mapping out your workflow and then planning some small tests of change with the workflow. So knowing the intent of a meeting and the purpose goes a long way. The necessary redundancies, this came up, it was several years ago now, but we were doing that team roles worksheet, and we were talking about whose role is it? Is it my role? Is it the next person's role? And someone in the group pointed out, because I was saying, if you have redundancies, you want to stop and think about, do we really need two people doing it? And the person in the audience said, sometimes though we do have necessary redundancies. Sometimes we have where, I think in their case, they had a PHQ-9 being implemented, and the 9th question is about suicidality. And their organization felt that not only asking the question on the paper, but having the next person ask the question verbally worked for them. It was an assurance for them that they were really being thorough because they had had a bad situation. So necessary redundancies are worth talking about and knowing where they are necessary. And then data as a team member, when you do have meetings or team meetings, is data at the table as well? I think data is a really powerful thing that we tend to be afraid of or worry about. And so, leadership has to present data in a way that's really going to fit the culture. It's got to be, we're looking at data because it helps inform the daily actions that we take. It's helping to give us a sense of our value. We can feel like we're doing a good job, or at the end of the day, know that we really connected with some of the clients we work at. But data is equally important in knowing. And some people say it doesn't exist if there isn't measurement. More payers are looking at that kind of thing. Funders, partners want to know what kind of data are we looking at. And it can be really informative for staff to see how the daily work that they do, the small steps they take throughout their day, influence the bigger picture of data, whether it be clinical outcomes or reducing no-show because of the increased effort you've put into engaging and activating people as they come in. Data is a critical part of that. And then the last one there about contingency planning. We implemented a statewide initiative at one point where teams hired care coordinators for the first time, hadn't really had that function. And some of the teams said, gosh, my care coordinator unexpectedly was out on maternity leave, or we had a care coordinator go on a 2-week vacation. What happened in the meantime? Not everybody really had thought through, and so they had some clients falling through the cracks. Or they had someone that started in the position, built up a caseload, and then left, and they didn't have a second person. So just having a plan for things that could come up. People do have babies. People do go on vacation. People do change jobs. And so how does the team support each other so that the clients aren't the ones missing that? On the next slide, I'm giving an example of how to do as a team a systematic case review. A lot of different ways this can look, but what this is a registry. So it's a list of all of our clients or patients around some given condition or issue. In this case, it's around being discharged from a hospital. So if we say we want to pull the data on everybody that's recently been discharged that is coming into our clinic, we might be looking at the discharge date and then what is their primary diagnosis, who's the provider, what are the short-term health goals, and their current level of care. So I just kind of made this one up. You'd want to think about what's applicable to you. But it's a way of looking at all of your clients in a given cohort. And the word systematic is really important here. It's not that if we don't do something systematically, we might just be thinking of those clients that are top of mind, right? The one that came in recently in crisis. Or someone who comes in often, but we just can't seem to be able to help manage symptoms with them. This way is saying everybody that's within our care, we're looking at all of those cases. It helps us with people that might fall through the cracks. So it's a way for a team to sit down, and some teams will do this once a week in addition to daily huddles, but they'll sit down once a week, that core team, and they will very quickly go through all of their cases. If you're familiar or you have an ACT team, this really is similar to what an ACT team might do. They'll very quickly go through everybody in the cohort, and they'll identify next steps. They might look at this group of patients, this little sample, and you've got the third person on the list is at a level 4 for level of care. That might tell you something about next steps. The person who's looking to find stable housing, who on the team is going to connect them to someone that does housing support. So very quick, systematic case reviews really help us as a team communicate effectively and comprehensively. The next slide, speaking of case reviews, is the SBAR method. And this is a way of formatting your communication in those case reviews or even in other settings if it seems to be appropriate. It's the idea of not starting with background, which is where we often tend to start. We often start with, I've got a 21-year-old female, she's been coming into the clinic for 3 months now. We go into all of that history, and this is actually suggesting we start with the situation. And I will tell you that primary care providers really love this. We had some practicing we were doing with some groups a couple years ago, and we had a primary care provider receiving the case in this SBAR format, and they continually had to keep stopping people and saying, I don't need all that background. I need to know what is the situation. And then I need to know a little bit about the background, but then I need to know your assessment and your recommendations. And so it takes a lot of discipline and practice, frankly, to get really good at being concise and giving just enough information to the team so that they can make some quick decisions and move on. And maybe the decision is that we do need someone to sit down with this person's case and really dig deeper because there's a lot going on. But following this kind of format is a nice way to quickly summarize the key things, starting with what's the situation today, what are the main concerns, what do I need to know, then a little bit about the background, and then that assessment and brief recommendations. And the recommendations might be the care coordinator saying, I really think this person needs to see Dr. So-and-so again because they said they've stopped taking their medications and I'm concerned, right? So the recommendation, it's not that you have to be an MD to make a recommendation. It's in your opinion of what you know so far based on the information, what do you suggest be the next steps? Next slide is, I have another poll question. I'm curious about really either SBIRT or any other structured format. SBIRT is a good one, but it's not the only one. Do you currently use some kind of structured format? Is it clear to everybody when you sit down or stand up for case review that everybody knows the format in which you're going to review those cases and it's done consistently every time?
All right, I'll go ahead and close the poll. 63% were unsure.
Oh, okay. That's really interesting and helpful. Again, don't be shy about using the chat box. I'd love to hear from those of you who are unsure what contributes to that. Is it that sometimes it seems like it's formatted, but other times we tend to go off on different tangents? Or the person leading the meeting, I'm not sure what they use. To that end, it's really good if you rotate who does the leading of the meeting and who takes the notes. It's really nice for level setting and team trust if everybody rotates their roles and has that opportunity. So I welcome your input on the unsure. And with that, we can go to the next step, which is another piece beyond doing then the case review. It's the follow-up. So, do you have protocols for when you would step a person down or step a person up in care? If you think back to the sample I gave, that one had some clear indicators. If their level of care went up or down, that tells us something. Do you have barometers, so to speak, on things that tell you whether this person needs more or less? PHQ-9 is another example. Some teams will say, if we haven't decreased their PHQ-9 score by 5 or more points, which is clinically indicated as a significant change, then we step up care if we haven't decreased their PHQ-9 score. Clearly we can do things like that around blood pressure. There's good best practices and good evidence around blood pressure. So that kind of thinking, as a team, do we know when we need to increase or decrease care? Relapse prevention is another really relevant thing, because you guys are seeing a lot of people, and how do we know if someone's gotten better? How do we help them before they leave us if they've gotten better? How do we help them feel prepared in case they relapse, or in case they need to come back into a higher level of care? That language tends to be, I think of relapse prevention around depression in particular. It applies to some other things. But how do we help clients know when to appropriately use our services and when to come back? And then that whole idea of defining success, that comes from setting up client-centered goals. It comes from measuring to the degree we can measure clinical progress, like that PHQ-9, and having that shared accountability for reaching different levels of success. And sometimes success is small, relatively speaking, for someone that's had a lot of things going on, but helping in communicating successes within the team and with the client. So the last section now, this is my favorite part. This is all about, now that we've thought through all of this stuff, how do we really engage and how do we really influence? So the next slide is a quote that tells us that most people won't really listen or pay attention to your point of view until they become convinced that you've heard and appreciated theirs. So all the communicating we've been talking about, we tend to think about what I need to say or do, but this is really saying, how much am I listening and knowing where the other person is coming from? So on the next slide, I took, if you're familiar with motivational interviewing, there's this idea of the spirit of motivational interviewing. And it includes these 4 tenets of partnership, compassion, acceptance, and evocation, or drawing out from the other person what they think, what they envision. And if you take partnership and compassion in particular, what this is asking us to do when it comes to effective communication is, first of all, choose curiosity. To withhold judgment, to express interest in the other person's opinions, frame of reference, and then thinking about, in what way do I contribute to the overall goals or mission of this organization? That's helping me more align with others, because I want to be in partnership with them if we have similar values, and I see that we both are contributing to that. And then that third spot there about, asking, how can we work together? How can we best make this happen? Anytime we use we, and we use we genuinely, we're showing partnership. We're showing that, we together, it takes more than one. None of us is as smart as all of us, that we really need that kind of combination together. And then the next slide is one more way of looking at this spirit of motivational interviewing, which takes the other 2 pieces, acceptance and evocation. And as far as acceptance goes, we all have colleagues that have been around a long time. And sometimes people that have been around a long time are perceived as those that don't want change. And so it's really valuable to honor historians, honor the people that have seen the organization go through a lot of change. And it's kind of that rolling with resistance, if you're familiar with that too, that there are people that might say, well, this is the way we've always done it, so that's why we do it that way. There's some value in that, right? We need to ask that. We need to inquire about that. And accepting or appreciating that someone that's been around a long time has a lot of value to bring to the team. And then lastly, clearly, this is the evocation part of it, is that, as Stephen Covey would say, seek to understand then to be understood. So really asking good questions, being curious, and drawing out from the people around their perspective before we push our part of being understood. The next slide takes into account this same spirit, and when we're ready or feeling the need to give advice or to share our perspective and to contribute to a conversation, we should do it in the spirit of partnership, compassion, acceptance, and evocation. So a very specific way of doing that, go to the next slide, is what's called this sandwiched approach in motivational interviewing. It's where prior to giving the advice, which is actually the sandwiched part, we start by eliciting or asking our colleague, our supervisor, our leader, or client, what do you think? What's your take on this? I'm curious what you already understand about the change our organization is taking place. Asking first, because then what we can do is we can tailor our information based on what we were just hearing from the other person. And it gives that other person, usually they're more willing to hear from us because we've sought out their thinking first. And then very importantly, we want to also end on an eliciting note where we give the information we have to give, and then we ask, what do you think? Where does this leave you now that you've heard that? So maybe it's something like, gosh, we're going to have to start documenting X, Y, and Z in the EHR. So we might ask first, what do you think? How will that affect the work that you do? Any ideas? And then we might give some ideas of our own, and then we ask again, what do you make of that? What do you think? And so it really tends to enhance the conversation to give advice or information in a sandwiched way. The next slide is some particular examples of how we might engage someone in this idea of change talk. So any language that's in the direction of change. So drawing out another person's desire or want to see a change go through might come about by asking them, what would you like to see happen? What ideas do you have about what would be helpful? The ability as well. So how would you approach this? How often do we ask other people first what they think might be useful versus telling them how we want them to do it? So just some other examples there. What's most important to you? What are the 3 best reasons that you think it would be for our team to, be part of this new project? What might be your next step? Asking any of these questions tends to draw out more change language from the other person because we're seeking their opinion, we're drawing out their reasons or their needs to see the change happen. And the next slide is just to say that there's some linguistics studies that have found that even if a person doesn't appear ready to change, whether it be a client or a coworker, the amount of change talk they give is actually more predictive than that level of readiness. So someone might appear to be a pre-contemplator, but if they start talking in language that demonstrates a need for a change or an ability to make the change happen, that tends to move them along the readiness path closer to action. So we're really always looking to help people say out loud their own ability, reasons, need, and things like that in order to drive change. The next slide I wanted to share with you some interesting research that it's called the Gordon model. And they talk about some roadblocks in communication. And these are things that often seem very well-meaning, but they can actually have the effect of diverting a conversation or blocking it, even if it's not intended. So for example, we might think we're being very helpful by giving advice or making a suggestion. That can be interpreted as, well, you don't trust me to figure this out by myself. So think of parenting with this, right? That, a parent that is telling a child, you should do this, or, why don't you go and do that? How much are we empowering them to figure that out for themselves? And that plays out for us as adults as well. Or reassuring. We might feel that it's appropriate to sympathize, or, gosh, I know what you mean, this has been so hard, and you'll be okay, you'll figure it out. Can sometimes be interpreted as, you don't think it's important. You're just, placating me with what you're saying. So all of these things I think are just worth thinking about. It's not that any of them are wrong, it's just they can be misinterpreted. Persuading somebody, trying to be very logical and talking things out. If we don't empower the other person, they might feel, oh, you don't think I could figure this out by myself. If I'm not ready or asking for you to help me think it through logically, that might not be what I'm needing. And then humoring, changing the subject, if we're not reading the right cues, that might not seem like you're taking me seriously because you're humoring me when that isn't what I was looking for. So with those 4 roadblocks in mind, my last polling question is having you think about this for a second. Which ones have you seen most commonly misinterpreted? As I was talking those through, which one do you see as having that potential to create roadblocks when we don't expect it? So it's giving advice, sympathizing or reassuring, persuading, or humoring.
All right.
Oh, wow. Okay, so 73% giving advice. And then the next one, persuading with logic. Yeah, interesting. I could interpret that in a couple different ways. Yeah, that's really interesting. Yeah, giving advice, I mean, providing solutions. I mean, we all love, getting help, getting solutions, but sometimes it's just not the right place, or it's counterproductive if we feel like it's disempowering to us. So, yeah, that's interesting. So, yeah, I think the Gordon model is something interesting to look into. I provided you the link if you want to look further into his work in that area. So just a couple more thoughts. The next one is there's a book out there that I've been referring to this book a lot over the years. It's not even a healthcare book, but it's Robert Cialdini put it out there about the psychology of persuasion. And I mean, this book, again, is not a healthcare book, but a colleague of mine and I years ago really thought about how it does have some applicability to the work we do in healthcare when we are, in a way, trying to influence or persuade or encourage, inspire our clients to make changes or our colleagues to be the best they can be. And so 2 things in particular. There's something like 8 or so elements in this book. But the next slide, this idea of liking, and it really comes around when you think about Facebook. A simple and effective way to be influential is to be likable or to create likability in the work you're doing, because we're persuaded by that, right? Facebook is a huge trigger for that, collecting those likes on the page. A simple example is creating a group for clients to attend that is titled Tobacco Cessation. Doesn't sound as fun, perhaps, as a group or staff. I guess I said clients, but maybe it's even, you want to implement tobacco-free campus. So I could attend, I smoke and I'm on the staff. I could attend a tobacco cessation class, or I could attend a staff wellness class. Simple things like this can really influence, if you will, our willingness to be part of a process or to be communicating more effectively. So simply that idea of creating a more likable or desirable influence can go a long way. And then the other one I pulled out for you is about commitment. If you remember the no texting commitments, if you will, that were coming out for a while there, they probably still are with texting and driving. We want to, by human nature, we want to show we honor commitments. We want to be congruous with what we say we will do and what we actually do. And in Cialdini's book, he looked at people that were requesting that a person take a specific action and then waited for their response. So would you stop at the front desk and make your next appointment? Or will you be sure to call us if you need to reschedule? Just that simple act of waiting for the person to respond and verbally commit and say, yes, I will, actually increases the likelihood that they'll do that and comply with that by like 2 to 3%, or I'm sorry, 2 to 3 times as often are they more willing. Now we know this isn't 100% foolproof, but it's a very simple act that we can take and ask, what is your next step? or asking a client when they're thinking about their action plan or their goals to have them write them down. Maybe you make a photocopy, maybe you type it in their chart as they're writing, but asking for a commitment and having the person actually write it down really increases the likelihood. So very simple things we can do even with each other. You know, I'm going to commit to doing X before next week's staff meeting. Increases the likelihood that I'll follow through. So with that, my last slide is to stop talking at you and gather some comments or questions. I'd love to hear what resonated, what didn't, what was cool, what was confusing. We have about 5 minutes to respond to comments and reactions.
Hey Pam, this is Joan, and I just wanted to say thank you. I think everybody, when we did the last webinar, people were very quiet. I'm hoping that means they're thinking and that we'll be able to follow up with some additional questions. But I want to thank you. I had some new insights as you were talking and found this to be really helpful. So, Stephanie, are there any other questions?
There are not.
Okay.
All right.
Wait, just came in. Oh, well,
great.
not a question, but they liked what you were saying pretty much. So it was a compliment. But
I'll take that on a Friday afternoon. Yeah, I'll just reiterate that I think communication is such a big topic, right? And I do think it starts with that high level. What are we trying to do here? Is everybody on the same page? And then how do we organize ourselves to be as optimal as possible? And then what are those messages, those techniques, if you will, those strategies to effectively, so take from that what you will and where you find you really resonated. And I think, that's the way in which we do this complicated work of healthcare and teams.
Thanks, Pam. And I want to, before you all go, I want to remind you that next Thursday at 1 o'clock your time is our first virtual learning community meeting, our first group call, and hope you all will join us. As you think about Pam's content, you have questions, you have comments, feel free to send those to me or to Stephanie. We'll compile them, use them as part of our agenda, but really look forward to getting with you, finding out what all of you are doing and what kind of questions and thoughts you bring. So have a great weekend, everybody. We on the East Coast here, it's 4:30, so we're going to be signing off to head out to a beautiful weekend on the East Coast. I hope the weather is great in Montana as well. And talk to all of you next week. Bye-bye.
Bye-bye. Thanks.
bye, thank you.